Advances in the recognition of substance use disorder as a treatable medical condition have led to the development of life-saving, evidence-based interventions. Access to long-term recovery support in the community could further increase people's chances of attaining sustained remission. I'm Stephen Morrissey, managing editor of the New England Journal of Medicine, and I'm talking with John Kelly, director of the Recovery Research Institute at Massachusetts General Hospital and a professor of psychiatry and addiction medicine at Harvard Medical School. Dr. Kelly has co-authored a perspective article about integrating clinic-based care with community-based services for people with substance use disorder. Dr. Kelly, why have policies that are focused on criminalization of drug use, such as those leading to arrests for drug possession, not been effective at supporting recovery from substance use disorder?
Well, they're a mismatch really for the nature of the condition and the root cause of the crime, because generally using a criminal punishment to address medical disorders has not worked historically. It's not working now. When we look back over the last 50 years of really addressing what has been termed the war on drugs, we have seen firsthand the failure of harsh punitive rhetoric and rigid sentencing laws, and in failing to address these endemic and intermittently epidemic problems related to alcohol and other drug disorders. So we have good observational evidence of the nature of these conditions now, and also the more appropriate ways of addressing them vis-a-vis treatment and recovery support services.
So, how has our understanding of substance use disorder and approaches to addressing it changed over those 50 years?
One of the things that we've learned in the enormous amount of things that we have learned in the last 50 years since the birth of the National Institute on Alcohol Abuse and Alcoholism and the National Institute on Drug Abuse in 1970 and 1974, respectively, that's really produced 90% of the world's knowledge on addiction. We've learned a lot about causes of addiction, the etiology, the epidemiology, the neurobiology, the phenomenology of all these disorders. But most importantly, I think, from a care perspective, has been the recognition that these tend to be chronic conditions, that they are susceptible to relapse even after good treatment, good high-quality treatment. They are susceptible to relapse for not just months, but many years after initial remission. And this has been one of the most important, I think, discoveries in the last 50 years, is this recognition of vulnerability and susceptibility over many years. In contrast to that recognition, of course, is the misalignment of our treatment and recovery support services historically during this time, because most of our treatment protocols have been tested over 12 weeks. So they're generally 12 weeks of implementation of a pharmacotherapy or a psychosocial treatment historically, and then the removal of that treatment and then a follow-up for 1 year. Now, that's good if you're treating an acute condition, but when you're treating a condition which is susceptible to reinstatement and recurrence over many years, then we really need to implement services and test services that can support someone over that longer period. And this is where we have arrived at in the last several years now, is recognition of the need not just for longer-term kind of chronic disease management in the clinical realm, but supporting that and linking with services and infrastructure in the community that can support people in the places where they live and work.
What do those types of programs look like? What do they entail?
So there's been a huge growth in the last 30 years, in particular in the variety of these so-called recovery support services that are community-based. The idea here, and this has been empirically tested, is to support and augment, amplify, and extend our clinical infrastructure, the more expensive services that are provided to address these endemic problems nationally, by linking patients to these freely available, ubiquitous recovery support services. These are typically populated and run by peers with lived experience of active addiction and recovery from it. So these are people who've had a prior substance use disorder, now living in recovery, who want to help other people who have the same condition. There's been, of course, a long precedent in terms of mutual help organizations. I think most people will know of groups like Alcoholics Anonymous, Narcotics Anonymous, that have been around for 90 years and have now a strong evidence base, particularly regarding alcohol, and Alcoholics Anonymous, to support their clinical and public health utility as a means of supporting people and sustaining remission over time. People are familiar with those, but now there's a very large variety of other kinds of so-called mutual help organizations, again, peer-run, that can embrace other sufferers, help to destigmatize, which people feel a lot of stigma and discrimination who have these disorders by virtue of the fact that they are meeting people who themselves have had these problems and have found a way out. So they're populated with peers across the spectrum of a variety of mutual help organizations like Smart Recovery, LifeRing, Women for Sobriety. There are a variety now of online resources that people can access, which has been kind of a silver lining of COVID, if you will, in terms of really amplifying the value of online resources and access to those. But that's not the only flavor of recovery support services. There are many others, including recovery housing, finding a safe place for people to live in the early months and sometimes years of their recovery journey, where they need an environment that's supportive and conducive to healing and long-term change. Again, populated and run typically by peers who themselves are in recovery. There also has been a growth of so-called recovery community centers, sometimes called peer recovery support centers. These are, again, peer-led. They provide access to all kinds of things. These are not residences, but rather places where people can go during the day to get support from other peers who have had these disorders living in recovery, gain access to things like housing, jobs, education, gain access to social services that can help them if you're a young mother in recovery, gaining access to the kinds of services and supports you might need to access, as well as learning how to write a cover letter for a job, gaining access to employers that will take people with prior criminal convictions, because, as you mentioned, we've had a problem in criminalizing these disorders, and that makes it very hard for people to be able to get a job, to get a loan, to get a bank account, to get the kinds of things that they need to build optimism and hope for the future and gain traction in recovery. There's also a number of other recovery support services in employment and educational settings. So there are these things called employment-ready workplaces, where employers and large organizations actually go out of their way to provide services and accommodations for people who have these disorders and are also coming back to work after treatment, so that they can support people to maintain remission over time. The biggest economic burden, as some listeners may know, is actually from lost productivity that's attributable to substance use disorders and, by extension, mental health disorders. The biggest economic burden, 80% of the economic burden attributable to these disorders, is from lost productivity. That is not going to work or calling in sick. So it behooves employers, in other words, to really go out of their way to help people stay employed, stay in their job, come to work, and be productive. And so there's a huge economic benefit and incentive for employers to do that. And that's been a growth area. Also, in educational settings, there has been the growth of recovery high schools. So these are high schools that are run oftentimes by people with lived experience themselves, but who are also teachers. And so they help to provide a safe environment that's supportive and conducive to young people, teenagers who have substance use disorders, so they can have a safe environment that maximizes the chances of recovery for them. And in colleges, there's been a growth nationally and internationally on so-called collegiate recovery programs. These are services and programs on college campuses that can provide a safe haven, support from other peers in recovery, as well as staff that can provide access to services that can support remission in those high-risk environments.
Finally, what types of policies at the local, state, or federal level are needed to increase access to recovery support services and to promote substance use disorder recovery more generally?
I think the expansion, the recognition of the need for these kinds of services, this has been happening. It needs to happen, I think, and accelerate more as we've learned more clearly, again, about the nature of these disorders, the susceptibility to recurrence of these conditions. The good news is we've gotten some very strong, powerful clinical treatments, most notably in terms of addressing the current opioid addiction crisis through things like buprenorphine and naloxone and extended release naltrexone and other extended release versions of buprenorphine. These have been very important lifesavers, literally lifesavers in preventing overdose deaths, and that's been critically important. So we need to amplify and extend access and accessibility and availability of these life-saving treatments. But in addition to that, ensuring that we have adequate appropriation at the state and federal level to create and expand these so-called recovery support services and the infrastructure, because these are shown not just to be effective, but highly cost-effective also in reducing the national burden of disease and disability and premature mortality, as well as economically attributable to these conditions. So it's a good investment for state and federal governments. This has been recognized to some degree already in the expansion. For example, the legislation that's been proposed nationally at the federal level to increase block grant funding for substance use disorder treatment, to mandate at least 10% of that block grant funding for SUD, for substance use disorder, to be appropriated for recovery support service infrastructure expansion. So that's good news, because it's a start to recognize the need to move beyond largely acute care services to provide community-based, accessible, available, local services that people can attend and increase their chances of long-term stability and remission in the communities in which they live and work.
Thank you, Dr. Kelly.